Hi, I'm David Portnoy, and I'm going to be talking about sarcomas today. This is a really broad topic, and it's hard to compress all the important information into one talk, but I'm going to try to do my best to hit on the highlights and the important aspects of this very large topic. So sarcomas are cancers that arise from muscle, fat, nerves, blood vessels, bone, and everything that holds all the different parts of the body together. What I like to tell my patients is that cancers that we name after a body part, such as lung cancer or breast cancer or prostate cancer, we think of those as, those are typically carcinomas. And then we have our blood cancers, leukemia, lymphoma, multiple myeloma. Sarcomas are a completely different third group, different than the others, and they can occur anywhere in the body. And they're extremely rare. As a whole, they make up less than 1% of all cancers. Because they're rare, they can be easily missed, and it's not uncommon for patients to have a significant delay in diagnosis, even if they see their doctor, just because they show up in weird places, such as the thigh in this person. And you know, no one thinks of getting thigh cancer, but this is how sarcomas often present. Like I said, they're very rare. And there are many different types, and that's part of the reason sarcomas are so hard to treat, is they're rare, and there are a lot of different sarcomas. And because none of them occur in huge numbers, they're very hard to study. But we like to lump them, to simplify things a little bit, into two big groups: bone sarcomas and soft tissue sarcomas. Bone sarcomas are much less common than soft tissue sarcomas. There are only about 3,000 new cases of bone sarcomas in the United States per year, so this is a really rare cancer. And a death rate of about 1,500 per year. And as you can see in this graph, bone sarcomas are about equally as likely to occur in children as they are in adults, although the types of bone sarcomas that are seen in children differ than the ones that are more commonly seen in adults. Soft tissue sarcomas, on the other hand, are much more commonly seen in adults than children, about 12,000 a year and about 4,700 deaths per year. Tissue sarcoma. We don't know why these occur. Most of the time, they occur without any identifiable risk factors. However, in a minority of cases, we can identify some risk factors that could put people at high risk. Genetic syndromes can be associated with sarcomas. It's not common. Leishman-Menie's probably the best example. This is a very serious genetic mutation where all different types of cancers can be seen, including breast cancer and other carcinomas, often at very young ages, but you can see sarcomas with those. Neurofibromatosis can be is associated with malignant peripheral nerve sheath tumors, and to a lesser degree, GISTs. Gardner syndrome is a variant of Lynch syndrome, which is really, I'm sorry, it's a variant of a familial colon cancer syndrome, not Lynch syndrome, but can be seen, in Gardner syndrome, you see a lot of desmoid tumors. Retinoblastomas are seen in the retinoblastoma syndrome, which is typically a pediatric issue. Radiation therapy can predispose patients to sarcomas, especially osteosarcoma. Typically occurs 15 to 20 years after the radiation therapy takes place, and I'll be discussing this later in the talk. But this is, radiation-induced sarcomas make up a small minority of all sarcomas. There are certain exposures, environmental exposures, that can cause sarcomas. Mesothelioma is actually a sarcoma, although we think of it more as a type of lung cancer, and it does involve the chest usually, but obviously it's seen with asbestos exposure. Patients who are immunocompromised, such as having a kidney transplant or HIV, are at increased risk of Kaposi sarcoma. And Kaposi sarcoma is also associated with HHV8, which is a virus. I'm not going to be talking about Kaposi sarcoma in this talk. It's treated very differently than, or it's treated differently than other sarcomas. Often, treatment just involves treating the underlying immunocompromised state, such as treating the person's AIDS, although chemotherapy can be used. And then lastly, and this is very rare, lymphedema can predispose patients to lymphangiosarcoma. We look at cytogenetics. So cytogenetics, looking for genetic mutations, is actually really important in diagnosing sarcoma. Sometimes it's unclear if what a biopsy shows, if it's showing a sarcoma at all, and if it is, what type of sarcoma it is. And in those situations, looking at different translocations and mutations can help us come up with a diagnosis and also help determine the ideal treatment for patients. And this is just a small sample of the total list of mutations and translocations we look at when trying to diagnose someone with a sarcoma. This is very similar to a lot of the hematologic malignancies where we use cytogenetics to help come up with the correct diagnosis. So I'd like to focus first on soft tissue sarcomas as a whole, but we'll definitely try to hit on some subtypes. Typically, these show up as an enlarging mass somewhere in the body, such as in this person's thigh. They're usually asymptomatic, and what we'll often hear patients say is that, yeah, I had this lump growing on my arm or my leg for about 3 months, and then it got bigger, and then after a while I showed it to someone, and they thought it was just benign, and then it got bigger, and I finally showed it to someone else, and then they looked into it. They don't have to be painful, but usually when they get to be a certain size and they start pressing on other structures, they can cause some discomfort. Sarcomas typically occur in the extremities. About 60% of these occur in the extremities, but they can occur in the trunk, and retroperitoneal sarcomas is a major group that we treat, and they can cause other symptoms such as obstruction just because of where they are. So they can lead to bowel obstruction, they can lead to hydronephrosis by blocking the ureters, so they can cause some symptoms just based on their location. But like I said, most of these occur in the extremities, about 30% occur in the trunk, and about 10% occur in the head and neck region. They can occur anywhere in the body, and that's one of the things that makes these hard to diagnose, because they're rare and they show up anywhere. The other challenge, there's so many of these. This is a list of most of the different types of soft tissue sarcomas, but there are others. And we lump them all together, but we really shouldn't. You don't lump all your carcinomas together. You don't treat every adenocarcinoma the same. You don't treat breast cancer and lung cancer and prostate cancer the same. So we probably shouldn't treat all our sarcomas the same, but it's very hard to get a good clinical trial of synovial sarcoma when they occur so infrequently. So unfortunately, we do often lump most of these together. This is a long list, but there are some that are more common, and the ones in bold are really the most common sarcomas we see, with pleomorphic undifferentiated sarcoma probably being the most common. That's basically your generic sarcoma. The old name for that was malignant fibrous histiocytoma, followed by liposarcoma, which is a cancer of fat cells and has nothing to do with body weight, and leiomyosarcoma, which is a cancer of smooth muscle cells. But then the list, as you can tell, is very long. Whenever we approach sarcomas, it's really necessary that this is approached from a multidisciplinary standpoint. It can't just be the medical oncologist, and it can't just be the surgeon. When we see that take place, that's when we see real errors in care and inferior care. Because they're rare, it's always good to have it treated by a group that has experience in sarcomas. So we have tumor board. We have so many tumor boards now for all the different cancer types, but the sarcoma tumor board has been meeting for years, a lot longer than I've been taking care of sarcomas, and it's been really helpful in making sure that our patients here get good care. So we meet, and it's me, and it's radiation oncology, and surgical oncology, and orthopedic oncology, and musculoskeletal radiology, and a sarcoma pathologist. And we meet once a month, but we're on the phone almost every day trying to coordinate our care and figuring out who needs radiation, who doesn't, when should the radiation take place, should it be before or after the chemotherapy, what kind of biopsy should we do, who's going to do the biopsy, what part of the mass is going to be biopsied. These are all discussed, so there's a lot of coordination that goes on with these cancers, and what we find is when you have a good team approach, it's a lot smoother. The treatment is set up quicker, and patients do better, and that's been shown multiple times. In terms of the diagnostic workup, soft tissue is best seen on MRI. So MRI is often your ideal imaging modality for visualizing the primary tumor site. This shows right here a sarcoma in the soft tissue of the thigh. CAT scan is often, used first, but really MRI is going to be better. When these cancers metastasize, typically the most common site of metastasis, with the exception of a few such as GIST and primarily GIST, is going to be the lungs. So we typically will do a CT scan of the chest as part of the metastatic workup. So it'll be MRI of the primary tumor site and a CT scan of the chest. In a few specific histologies, we will perform some other imaging tests. Some liposarcomas and other sarcomas require imaging of the belly, such as angiosarcoma. Myxoid and round cell liposarcoma, we do MRIs of the spine. And angiosarcoma and alveolar soft part sarcoma, we will proceed with imaging of the central nervous system. PET-CT scan is interesting. Most of the time we don't need it. In the lungs, actually, often regular CT is better because we're looking for very small pulmonary nodules, and a CT scan is actually better at picking those up than PET typically. But PET-CT scan can be helpful if we're treating someone with neoadjuvant chemotherapy or chemotherapy even in the metastatic setting, and it sometimes can predict a response to therapy before we see radiographic shrinkage of the tumor. So PET-CT has a limited role in sarcomas, but it is used sometimes. How the biopsy is obtained is really important in sarcomas. Fine needle aspirate is almost always not sufficient. The specimen is just too small to come up with a definitive diagnosis. It's hard to do the cytogenetic testing, but it's also hard to see how the cells are lying in relation to each other, and it's just very hard to come up with a diagnosis by fine needle aspirate. So really the two primary biopsy techniques are open or incisional biopsy as performed by a surgeon, or core needle biopsy. Open biopsy will obviously get you the most tissue, but that's a surgery. So it puts the patient through a procedure. There's a recovery from that before they can start any treatment. And if it's not performed correctly and the planes of fascia are disrupted, it could theoretically lead to spread of the tumor. What we often see, unfortunately, is that patients will see a doctor who doesn't experience in sarcoma. They see a mass, they think it's probably nothing, but they decide they're going to take it out themselves, and then the surgeon goes in and in the operating room realizes that this isn't what they expected, and they've cut through the fascia and they've increased the risk of spreading the tumor, and then when they get sent to a surgical orthopedic oncologist who needs to do a re-resection, ends up being a much bigger surgery. So we prefer core needle biopsies. These can be done in our office. They're less invasive than surgery. There's really no recovery. They're safer. And typically, you can get enough tissue that way. So this is definitely our preferred biopsy technique. What we often do actually with sarcomas is, because we actually want the needle tract for the biopsy to be resected as part of the surgery, is we actually even have the surgeons do their own biopsies, their own needle biopsies. So even though we can do the needle biopsies here in the office, it's not uncommon for us to, if we see someone with a mass that we think is a sarcoma, we'll send them to the orthopedic oncologist, and they'll do their own biopsy, actually. So, but it's still a core biopsy, and that really is our preferred biopsy technique. Staging system for sarcomas is similar, but a little different than staging system in other cancers. It still goes stage 1 through stage 4, with stage 4 being metastatic disease. But we don't just look at the tumor, the size of the tumor, lymph nodes, and whether there's distant metastasis. We also look at the grade. So high-grade tumors are much more serious than low-grade tumors, and more so than in a lot of other cancers, grade has a significant prognostic impact on patients with sarcomas, with soft tissue sarcomas, and bone sarcomas too. Lymph node involvement is really rare in sarcomas. Only about 5 to 10% of all soft tissue sarcomas have lymph node involvement. We typically see it most commonly in a few epithelioid sarcomas, rhabdomyosarcomas, and angiosarcomas. Clear cell sarcomas can also have lymph node involvement, and it's a very bad prognostic indicator. It's almost the same as if they have distant metastatic disease. So lymph node involvement puts them at stage 3, but prognostically it's not much better than having distant mets. But in general, when we stage sarcoma, stage 1 are your low-grade sarcomas, stage 2 are your intermediate grade and your small high-grade sarcomas, and stage 3 are your high-grade non-metastatic sarcomas, and stage 4 are your metastatic sarcomas. When we talk about whether a sarcoma is large or small, the cutoff is 5 centimeters. So if it's under 5 centimeters, it's small. If it's over 5 centimeters, it's big. Prognosis obviously correlates with stage. Your small, low-grade sarcomas are going to have a higher cure rate than your metastatic sarcomas. Overall, alveolar soft tissue sarcomas is about 50%, although that includes patients with Kaposi sarcoma, and they have a poorer prognosis because they typically have comorbidities predisposing them to getting that disease, with the exception of elderly men from the Mediterranean who can also get it. But they have their own comorbidities because they're usually elderly, as I said. But a small low-grade sarcoma actually has a great prognosis. It's the metastatic sarcomas that do not, although you see the 5-year survival rate is not 0. So there is a small fraction of these patients who can do well long-term. Soft tissue sarcoma is a surgical disease. If you can remove it, you can cure it, and if you can't remove it, you can't cure it. So surgery is really the goal. Now, unfortunately, these tumors often present really large, and it's not uncommon to see a sarcoma that's greater than 15 or even 30 centimeters, and we'll see sarcomas in the thigh that are over a foot long. That being said, we still try to remove them, and we try to avoid amputation when at all possible. These surgeries end up being humongous, but over 90% of the time, we can still save the extremity. There might be some functional impairment, but we really try to avoid amputation when we can. So surgery is the goal, and any other therapy that we do in addition to surgery is with the idea of helping facilitate the surgery and making sure that the cancer doesn't come back after the surgery. Radiation therapy is well established in the role of soft tissue sarcoma for large tumors and high-grade tumors. It is an adjunct to surgery, meaning that if you can resect the sarcoma, we often would like to have either neoadjuvant or adjuvant radiation therapy to help eradicate microscopic disease. It's been shown to help reduce the risk of local recurrence. It is not helpful in eradicating gross disease, meaning if you have an unresectable sarcoma, palliative radiation therapy may be helpful, but it's not going to completely eradicate that unresectable mass. Its utility in the smaller and lower grade sarcomas is becoming more evident, and we're using it more and more now in smaller and low grade tumors that in the past we would have not performed radiation on. The radiation therapy can be given before or after surgery, and there are advantages to either one. Typically, we prefer preoperative radiation therapy here in Memphis. There are a couple of reasons. There have been some retrospective studies suggesting that outcomes may be better with preoperative radiation as opposed to postoperative radiation. But when radiation is given preoperatively, it's generally a smaller radiation field. It can help shrink down the tumor to make the surgery smaller and help avoid amputation. And also, a lot of times when these patients have their surgeries, they require skin grafts afterwards, and giving radiation therapy after surgery, after a skin graft is placed, can jeopardize the health of that skin graft, and sometimes those grafts can fail. So it's better to give radiation therapy, we think, before surgery, so if they need a skin graft, you don't have to radiate the graft itself. So typically in Memphis, when at all possible, we give radiation therapy before surgery. In our stage 1 soft tissue sarcomas, so these are our low-grade sarcomas. They can be big or small, but they're low-grade. Surgery is really the treatment. Radiation therapy sometimes, especially if margins are close or positive even, and then it's on a case-by-case basis in the completely resected sarcomas, maybe in some of the really big ones. And we follow them afterwards with CAT scans of the primary tumor site, occasional imaging of the place where the surgery took place, occasional MRI of the original tumor site. And we follow them a long time. So in the beginning, we start every 3 to 6 months for the first few years, and then we go down to once a year, but we often will follow them for up to 10 years because late recurrences are possible. Stage 2 and stage 3 sarcomas, really confusing. No real clear direction how to treat these. These are the NCCN guidelines, and it's really complex because if you read close, if you looked and read it, you realize it's not really saying anything at all. It's saying you could do radiation, you could do surgery, you could do chemotherapy, and you could do it all in any order you want. It's kind of like a choose your own adventure book. There's no direction at all with how to treat these, and radiation is helpful, surgery is helpful. We've discussed about the sequence of that. It is really controversial whether or not chemotherapy has a role in resected sarcomas. Most of the world feels that there is no role for adjuvant or neoadjuvant chemotherapy in resected, in the vast majority the majority of resected soft tissue sarcomas. However, you go to a place like MD Anderson, and they will feel completely differently, and they're very strong proponents of neoadjuvant chemotherapy for their large high-grade soft tissue sarcomas, and they're very strongly held opinions on both sides. I remember when I was taking for my boards, the ASCO review book was written by someone from Sloan Kettering who said very bluntly there is no role for chemotherapy in resectable soft tissue sarcomas, and I had a review video from MD Anderson, and they went on and on about how great neoadjuvant chemotherapy is in soft tissue sarcomas and never mentioned any controversy at all. And I want to just go over why that controversy exists. So this was a meta-analysis, a very large meta-analysis for sarcomas. It was almost 2,000 patients, and this was published in 2008. So in 1997, there was a meta-analysis of a bunch of smaller studies of adjuvant doxorubicin-based chemotherapy in resected soft tissue sarcomas, and it was a negative study. There was no real improvement in overall survival by giving adjuvant doxorubicin. But then people started combining doxorubicin with ifosfamide, and when they did when they included those studies in the meta-analysis, they saw that which you can see over here, there was an 11% improvement in survival, which is a huge improvement, bigger than you would see with cancers like colon cancer and big and rivaling similar to what you'd see in or even better than what you see in other cancers. In lung cancer, that improvement's about 5% with adjuvant chemotherapy. So you're like double what you would see in lung cancer, the same or better than what you see in breast cancer. So this was a huge finding and suggested a real strong benefit to adjuvant chemotherapy. But meta-analyses have a lot of biases. These were retrospective. Some of these were retrospective studies. They were small series. There's definitely going to be a publication bias, and studies that were negative probably never got published. So it's always hard to make treatment decisions based on a meta-analysis like this, especially when we have this study. So this is the largest prospective randomized clinical trial for adjuvant therapy in soft tissue sarcomas. And what they did was they took people who had grade 2 and grade 3 soft tissue sarcomas, and they either, after they finished their surgery and they might have had radiation, they gave them chemotherapy with doxorubicin and ifosfamide, or they just watched them. And what you can see here is that the overall survival was exactly the same. There was no benefit at all to getting chemotherapy in this study, and this led most people to really abandon the idea of adjuvant chemotherapy. But there are some very legitimate criticisms of this study. First of all, they included some histologies in the study that have no chance of responding to chemotherapy, such as GIST tumors. GIST is completely chemotherapy refractory, so of course they're not going to benefit from adjuvant chemotherapy. There were some patients in the study that had very small tumors that you wouldn't necessarily want to give adjuvant chemotherapy to. So there were some patients that really didn't belong on an adjuvant chemotherapy study. The other issue is that the ifosfamide dose was very low, and I'm going to get into this later, but we know that higher doses of ifosfamide work better in soft tissue sarcomas, and when people typically give adjuvant or neoadjuvant chemotherapy, they use an ifosfamide dose of 10 grams per meter squared. So they're giving half the dose of ifosfamide that we typically use. So it led a lot of people to question, was this study negative because the regimen is really not helpful, or was it negative because they undertreated the patients? So my personal feeling is that the benefit, there's not an 11% benefit as the prior meta-analysis showed, and there's not a 0% benefit that this study showed, and it's probably somewhere in the middle, somewhere around 5% benefit, which is not huge, and as I'll get into a little later, the toxicities of this regimen are severe, and there are some very serious long-term toxicities. And my personal feeling is that in most cases, the long-term toxicities outweigh the potential benefits, and the risk-benefit ratio is poor. So for the vast majority of patients, we no longer offer neoadjuvant or adjuvant chemotherapy to our resectable soft tissue sarcomas. There are a few exceptions, mainly patients who we think are extremely high risk of relapse, and patients who don't have easily resectable disease, where we think that their chance of having a complete resection would be higher if we could shrink it down with chemotherapy first. In unresectable disease, the role of chemotherapy is well established, but the prognosis is poor overall, with overall survival being only about a year or so. As I said before, recurrences typically take place in the lungs, and once in a while you'll find someone who has an isolated lung metastasis or a few that are resectable. And what's been shown is that in some of those patients you can get really impressive long-term survival and even cure. So in patients where you have isolated pulmonary metastases, especially those that took over 2 years to show up, you do see cures and you do see long-term survival. So surgical resection of metastatic disease is something we often look to do. When that's not possible, we can talk about ablation, embolization procedures, stereotactic radiosurgery, palliative radiation therapy, and I've talked about chemotherapy, and then isolated limb perfusion, where we isolate the limb and deliver chemotherapy just to the limb, which is something that's not commonly done but can be done in sarcomas. In terms of chemotherapy, these are the regimens that NCCN lists as available to patients with most of our soft tissue sarcomas. As I say in the bottom, this is not for all, but this is the common regimens. I highlighted the ones that we use most commonly. Our standard combination regimen is doxorubicin, ifosfamide, and mesna, also known as AIM. An older version of that regimen included dacarbazine, but it's been shown that dacarbazine just adds toxicity without benefit, so we don't tend to use that. Gemcitabine docetaxel is typically our second-line regimen. In terms of single-agent regimens, we use doxorubicin and ifosfamide as single agents, which I'll talk about in the next few slides. Liposomal doxorubicin is much less toxic than doxorubicin. It has a real benefit in cutaneous angiosarcomas and Kaposi sarcomas. We sometimes use it in other soft tissue sarcomas when patients have a lot of comorbidities and we don't believe they would be able to tolerate regular doxorubicin. It's not completely clear that it works as well as regular doxorubicin, but there are case series showing that it does have some efficacy. Pazopanib is an oral option that we will typically use often in the third line in soft tissue sarcomas, which is fairly well tolerated. Has not been shown to have a proven survival benefit, although proven overall survival benefit, but it does have a progression-free survival benefit of about 3 months. And it's oral, which patients like. Eribulin and trabectedin are the newest approved chemotherapy options for soft tissue sarcoma. They were both approved in liposarcomas and leiomyosarcomas within the last year. And they do have, they are gaining acceptance. And then paclitaxel is often used in angiosarcomas with good results, not used in other soft tissue sarcomas typically. Different sarcomas, as I've alluded to, have different degrees of chemotherapy sensitivity. So these over here are the most sensitive. Ewing's, which I'll talk about more later on in the talk, that's really a bone sarcoma, but can occur in the soft tissue at times. Rhabdomyosarcoma, synovial sarcoma, angiosarcoma, and myxoid liposarcoma are the most sensitive to chemotherapy. And then over here, as I mentioned before, these are fairly, not fairly, these are resistant to chemotherapy. So we would never give chemotherapy to these patients. We would give chemotherapy to the others. But of note, even in the adjuvant setting, it's not been shown that in a subsequent analysis of that European study that was negative for adjuvant chemotherapy, histology did not predict response. So even the sensitive sarcomas in that study did not have longer survival with adjuvant chemotherapy. Doxorubicin is our gold standard. It's our best drug for sarcoma. It's our first choice most of the time. We use a fairly high dose, typically of 75 milligrams per meter squared, which is higher than what we typically use in our lymphomas and breast cancers. There's been it's been shown there's a dose response curve. The higher dose you give, the better response you get. So that's why we give 75 milligrams per meter squared. One of the main concerns with doxorubicin, though, is that it's cardiotoxic. And as this graph shows, the more we give, the higher the risk of cardiotoxicity. So we often like to stay below about 450 milligrams per meter squared as a cumulative dose. If we go above that, or if we think someone's at particularly high risk for cardiotoxicity, we add in dexrazoxane for cardioprotection. There's always been this lingering concern that that might reduce the efficacy of the drug, but it's never been proven. Generally, we rarely use dexrazoxane. My personal feeling is if you need it, most of the time it's not needed till they've been on the drug a long time, and by that point it's unclear you will be getting any sustained benefit by continuing the drug at that point, because usually we can get 4 to 6 cycles before we need to even consider using it. So we do check echocardiograms every few months on these patients to make sure that they're not having a significant decrease in their ejection fraction. Really the main time I've used dexrazoxane is we have a clinical trial combining doxorubicin with another drug, and the study required 8 cycles of doxorubicin, which is more than we typically use. So we started using dexrazoxane in that study after 4 cycles. So for the cycles 5 through 8, we gave dexrazoxane. But in general, when we're not going beyond 6 cycles, there's really no need to give it. Other side effects include myelosuppression, nausea, vomiting, anorexia, and there's about a 1% risk or so of acute leukemia, which usually occurs a few years down the line. Unfortunately, patients' sarcomas, metastatic sarcomas, have a very poor long-term survival, and even if they're going to get leukemia, they usually don't live long enough for that to take place. Ifosfamide is is another drug we typically use in sarcomas. High dose ifosfamide especially can be very effective, but it's extremely toxic. We can give it along with doxorubicin. We can give it as a single agent. The dose is really high. As I mentioned before, in that European study, they were using 5 grams per meter squared, but in single agent studies, they've shown that you can get increasing responses or improving response rates going up to as high as 18 grams per meter squared, but typically we stop at 14 because above that the toxicities are too great. Of note, ifosfamide can give a very severe encephalopathy. It usually is mild. It's usually people are just kind of out of it. They don't talk very much. You get a lot of one-word answers, flat affect, but we sometimes see hallucinations, psychosis-like behavior, and in rare situations you could even get seizures. It's always reversible. If it's really bad, we can give methylene blue, which serves as an antidote, but typically the symptoms resolve within 24 hours of stopping the drug. So for the most part, we don't give methylene blue with this drug. If we are going with high dose ifosfamide, a single agent, we dose it twice daily and we put the patients in the hospital. So they're being watched anyway, and if they have mild encephalopathy, we'll actually treat through it, knowing it's going to get better. If they get really sick, or if we think they're a danger to themselves, or especially if they're having seizures or really bad mental status changes, then we'll give that methylene blue. And if we need to treat them again with ifosfamide, we can actually pre-treat them with methylene blue, and that's been shown to be helpful. The other thing we worry about with ifosfamide particularly is hemorrhagic cystitis, so we give Mesna with it, which is almost always completely effective at preventing the hemorrhagic cystitis. We do check daily urinalyses on these patients to make sure there's no blood in their urine. This drug is highly emetogenic. They lose their appetite, they get diarrhea, mouth sores, alopecia, fatigue, and they can get long-term liver and kidney damage. This is a really toxic drug. It's not used in most other cancers anymore because of all the toxicities, but we still use a whole lot of it in sarcomas, unfortunately, because it's been hard to come up with better medications. One of the big questions has been in our metastatic patients, do we give them doxorubicin and ifosfamide together, or do we just give doxorubicin alone? It's been hard to figure out which one is better. We know that both the higher dose you give, the better responses, but unfortunately a lot of the old studies used low doses of the drug, so we never really knew what was the right way to go forward. So this was a study that got published a couple years ago that I think answered the question pretty definitively. This was a phase 3 study, 455 patients, and they had metastatic sarcomas, and they were given either doxorubicin alone or doxorubicin and ifosfamide, and they found that the overall survival, median overall survival was 12.8 months in the doxorubicin alone group and 14.3 months in the combination group, which was not statistically significant. So really no significant improvement in survival with the addition of ifosfamide. 1-year survival was a little better, it was 60% versus 51%. 2-year survival was about the same, it was poor in both groups. So, and you can see in this curve, adding the second drug in terms of long-term outcomes did not have a big impact. Progression-free survival, or how long it took until the cancer grew, there was a small benefit that did reach statistical significance of about 3 months. So patients got the combination, went about 7.5 months without progression, and patients got doxorubicin alone went about 4.5 months. Where we did see an improvement with the combination was response rates. The overall response rate was only 14% with doxorubicin alone. It wasn't that much better with the combination, but it was better. It was about 26%. So, you know, like I said, survival is not that different, but you saw more patients having either partial response or stable disease or even a complete response with the combination than you did with the doxorubicin alone. So basically, the way we approach this is that in the vast majority of patients with metastatic soft tissue sarcoma, we use as our first-line chemotherapy, palliative chemotherapy, doxorubicin by itself. But if we need to shrink the tumor because the tumor itself is causing a lot of bad symptoms and we think the patient is strong enough and healthy enough to handle it, we can consider combination therapy. But that's a real minority, and most of our patients, for most of our patients, it's doxorubicin alone. And even though it's a pretty high dose of the drug, it's actually tolerated very well. When we give it a combination, we'll typically give the doxorubicin over 72 hours. There's suspicion that that might help reduce the cardiotoxicity of it. It's not proven, but that's what a lot of people believe. But in people who are getting it as a single agent, we give it as a bolus. It's just a lot more convenient that way. I mentioned before pazopanib is used. Pazopanib is oral. It's our one oral drug that is approved for the treatment of soft tissue sarcoma. It's fairly well tolerated. Sometimes people need dose reductions because of nausea or fatigue or hand-foot syndrome, but it is well tolerated. People were very excited about this drug when it came out because they thought it would be a lot easier than the chemotherapy options. But unfortunately, it's just not that effective. The progression-free survival benefit over placebo was only about 3 months, and only about 4.6 months, and there was really no overall survival benefit. It's still an option, and we still use it. We don't see a lot of tumor shrinkage with it. It's more tumor stabilization. It prevents things from growing, but doesn't necessarily shrink things down. GIST, or gastrointestinal stromal tumor, is another type of sarcoma that is fairly common among sarcomas, that is treated very differently than other sarcomas. These typically occur in the stomach, but they can occur elsewhere in the digestive tract. We think they derive from the intestinal pacemaker cells that kind of govern peristalsis and the passage of food through the digestive system. These cancers are completely insensitive to regular conventional chemotherapy. And for years, the treatment was really surgery, and that was it. But then people realized that there are certain mutations in these tumors that occur in high frequency, and with certain drugs you can target certain drugs that target these mutations can lead to very good sustained responses. So about 85% of these tumors have mutations in the KIT proto-oncogene, and another 8% have a mutation in platelet-derived growth factor receptor alpha. So that's about 93% of patients have targetable mutations. You never see cancers that have both. You don't see GIST that have mutations in both of these. But occasionally you'll see some that have neither. Those used to be called wild type, but they really do have mutations. They're just not in those two genes. Those can be hard to treat. Typically, these occur with bleeding because there's an ulcer in the stomach that is bleeding with these. Like I said, they most commonly occur in the stomach, but they can occur elsewhere in the digestive system. And about a third of the time they present with metastatic disease at diagnosis. Typically, they can spread to the peritoneum and liver. They can go to the lung, but it's less common. Unlike other sarcomas, which the lung is the most common site of metastasis, it's an unusual site of metastasis in GIST. Small GISTs that are considered low grade, that don't have a lot of concerning features, can actually be followed. But that's a very small minority of tumors. Most of them, the treatment is surgery. And sometimes we will give treatment before surgery to shrink it down to help facilitate the surgery. And in our larger, higher grade GISTs, after surgery, we will give adjuvant therapy in the form of imatinib. In our unresectable GISTs, we can try where we need to do something palliative. Locally, we can try radiofrequency ablation, chemoembolization, and sometimes even palliative radiation therapy works as well. Imatinib is our go-to drug for GIST. Second line is sunitinib, and regorafenib is our third line. I'll talk about those a little bit more. Sorafenib, nilotinib, dasatinib, and pazopanib all have small studies showing that they have some activity in GIST, but they are not FDA approved, and we typically save those for use after these three have already been tried. Imatinib blocks KIT and PDGFR alpha. It initially was used in chronic myeloid leukemia, where it's a real miracle drug because it blocked the BCR-ABL fusion protein. But it does have a significant activity, although not as good as in CML. It does have activity in GIST, with a 2-year progression-free survival of about 50%, and a 2-year overall survival of about 75%. And what's interesting is that there was a study a couple years ago where they looked at the original imatinib studies, and they found that about 20% or so of patients were still alive 10 years after being placed on imatinib, with some of them still on imatinib and some of them not, but it showed really significant long-term survival, better than expected. But unfortunately, that's about 20%, and median survival is about 18 to 57 months. Different mutations in KIT can lead to different sensitivity to imatinib. Exon 11 is the best. It's the most common mutation, and it's the mutation that makes you the most sensitive to imatinib. Exon 9 is less sensitive, but sometimes if you increase the dose of imatinib, you can still get a response. When when we talk about adjuvant imatinib or using it after surgery, we typically now recommend 3 years of therapy. It was first shown that 12 years was better than none at all, and then it was shown that 3 years was better than 12 years. What we don't know yet is if 5 years or more is better than 3 years. So we typically tell our patients at least 3 years of therapy after surgery for larger, high-grade GISTs. And sometimes, like I said before, we'll give imatinib before the surgery to shrink down the tumor, and that can count as part of the 3 years. Sunitinib is also used in renal cell carcinoma, but does have activity in GIST. It is often used when imatinib stops working. It is less well tolerated overall than imatinib, causes a lot of hand-foot syndrome, can cause some nausea, skin changes, rare cardiac issues. People don't feel that good. There's often a lot of dose modification that's required with sunitinib. We don't see a lot of tumor shrinkage with sunitinib, but we do see tumor stabilization. Median time to progression was about 27 weeks compared to placebo in patients who receive sunitinib after progressing on imatinib. It's not a great GIST drug, but it's better than what we historically had. Regorafenib is the newest FDA-approved GIST drug. This drug is also approved in colon cancer. This is a multi-kinase inhibitor. It hits a lot of different targets that can all be involved in growth of GIST. And in this study of patients who were extremely heavily pretreated on multiple lines of therapy, it improved the median progression-free survival 4.8 versus 0.9 months. And this is after they had been on many lines of therapy. We don't have the survival data yet with this drug, and probably in the study the overall survival data will be negative because it was a crossover study. So even the patients who were on placebo initially were able to get the regorafenib later on. So this drug has been used more commonly in colon cancer just because it's more common, but the study that showed this drug worked in colon cancer was published in the same journal at the same time as this study, and the editorial mentioned that they did not think it was a very good drug for colon cancer, but they thought it was a great drug for GIST. The two things I've noticed with this drug in terms of side effects, one is it does cause severe hand-foot syndrome, and sometimes we need to kind of start a reduced dose and dose escalate. The other thing is that we've seen some bleeding with this where we think it caused tumor hemorrhage. What was good, it was active against the tumors, but it was bad in that it caused the hemorrhage, which forced them to come off the therapy. So now, in the last few minutes, I want to switch over to bone sarcomas, which, as I mentioned before, are much less common in adults, and there's less known about them. One of the things that hampers our knowledge of bone sarcomas is, in addition to them being rare, is that because they're more well studied in children. So a lot of our treatment techniques are extrapolated from pediatric studies, and as we all know, children can handle things that adults do not handle well. So it's sometimes hard to know exactly how to treat these. Chondrosarcomas are the most common bone sarcomas in adults, with a median age of about somewhere between 30 and 60 years old. These actually are not seen in children primarily. So this is the one type of bone sarcoma that's more common in adults. Men are more likely to get them than females. They can occur anywhere inside or outside the bone. These are really cartilage tumors. It's a cancer of cartilage or cartilage-forming cells. Most common sites are the pelvis, femur, and the shoulder. They typically grow slowly. They can metastasize still. This is an X-ray showing kind of this, what they call soap bubble pattern. They usually present with some dull aching pain and an enlarging mass that is firm, but sometimes soft. So the clinical presentation will be a little bit variable. Conventional chondrosarcomas, which is the vast majority of chondrosarcomas, are chemotherapy insensitive pretty much. So there's really no role for chemotherapy. You try to remove them. If they're localized, you say radiation therapy. If they're not resectable, or if the margins are positive with resection. NCCN lists that you can use cyclophosphamide and sirolimus in metastatic disease, but that is based off of a very, very small case series. So unfortunately, these patients really don't have any systemic therapy options. So typically we'll send them off for molecular profiling and try to find a phase 1 study for them if they have metastatic disease. They can recur late, so we need to follow these people for at least 10 years because they can present with very delayed recurrences. Mesenchymal chondrosarcomas are very rare. They kind of present with a low-grade chondrosarcoma component along with a small cell or very high-grade component that resembles Ewing sarcoma, and we actually treat them with Ewing sarcoma chemotherapy. Dedifferentiated chondrosarcomas are similar, but they have a low-grade chondrosarcoma component with transformation to a high-grade osteosarcoma component or malignant fibrous histiocytoma of bone, and we treat these like osteosarcomas. They have a poor prognosis as well. Ewing sarcoma family of tumors is rare. They're only 6% of primary bone cancers, and they're most common in children with a median age of onset or mean age of onset of about 15 years. Almost a third of patients have metastatic disease at diagnosis. They typically occur in the pelvis and the lower extremities, in the diaphysis, which is kind of like the long middle part of the bone. But they can occur anywhere, and they can also occur outside the bone. That's called extraosseous Ewing sarcoma, and that's why we sometimes include them in soft tissue sarcoma discussion, because they can occur in soft tissues. Localized Ewing sarcoma has a very good prognosis, especially in children, with a 5-year survival rate of up to 70%. But in metastatic Ewing sarcoma, the survival rate is pretty poor. It's only 30%. They typically present with pain, a mass. There can be warmth over the mass. You can get flu-like or systemic symptoms from them, anemia. And this is an MRI showing Ewing sarcoma here in the middle of the bone. The classic question on when you look at X-ray is what they call an onion skin, because you see these layers of the periosteum being peeled off. Typically, we get an MRI of the primary tumor site. We definitely get a chest CT looking for small pulmonary nodules, because that is the most common site of metastatic disease. We often will get a PET CT or bone scan, because there can be metastases in the bones with these as well. And you can get intramarrow metastasis, so we often will proceed with a bone marrow biopsy or pan-spine MRI and MRI of the pelvis. Cytogenetics is very helpful in coming up with the diagnosis of these, because they're very high-grade tumors, and they're small cell tumors, and they can look sometimes like small cell lung cancer or even certain lymphomas. So cytogenetics is very helpful. With most of these cancers, because they occur in young people, we always have to counsel them on fertility, sperm, egg preservation, sperm banking, prior to therapy. In terms of treatment, it's kind of like a chemotherapy sandwich. We start them on chemotherapy, and then we do surgery and or radiation therapy if it's unresectable or if margins are close, and then we complete the chemotherapy after surgery. In terms of chemotherapy in the United States, we typically use, in the non-metastatic Ewing sarcomas, alternating cycles of vincristine, doxorubicin, and cyclophosphamide with ifosfamide and etoposide. The VAC can be given in the office. They do wear the Mesna pump for 24 hours after they get it because of the high-dose cyclophosphamide causing hemorrhagic cystitis. The ifosfamide etoposide is given over 5 days. We typically do that in the hospital, but it can be done as an outpatient. In the metastatic setting, the IE doesn't seem to add much, so we just treat them with VAC alone. In Europe, they use vincristine, ifosfamide, doxorubicin, and etoposide instead. There's a study going on right now comparing these two regimens to see which one is the best, but right now it's a regional difference, and this is our preferred regimen in the United States, where we do see a 5-year cure rate, 5 years of overall survival rate is about 70%. So we do see good results in the non-metastatic setting with these, especially in children. In relapsed and refractory Ewing sarcoma, responses are poor, duration of response is poor. You can see responses, but unfortunately, overall survival is pretty bad. These are the regimens we typically use. We've also looked at stem cell transplant, and there's some conflicting studies on those. It's not clear how effective that is. We sometimes do lung radiation, whole lung radiation, which is something more commonly done in children. But unfortunately, there's not a lot of standardization and not a lot of recent breakthroughs in the last really 20-plus years that have advanced the treatment of the disease. Giant cell tumors are interesting. They're considered benign, but they're not really benign. These are large lytic tumors that can occur in bone. They have giant cells, which are similar to osteoclasts, which are bone-dissolving cells, along with stromal cells that are really the tumor cell. they're considered benign, but they actually can metastasize to the lungs. Nevertheless, they tend to grow very slowly, and even though they do spread to the lungs, the metastases can almost always be removed. So it's very hard to die from these. However, they can be very painful, and we do see a lot of pain, and we do see a high risk of local recurrence. So when surgery is not possible, our go-to drug is denosumab or Xgeva. This is a bone strengthening drug that we use, and it's been shown that it helps heal bone up. It's been shown to help reduce the risk of recurrence, help shrink tumors down so they can have a less morbid surgery, and sometimes even avoid surgery altogether, and it's extremely well tolerated. So this is really becoming standard of care in large or recurrent giant cell tumors. And this showed that when they gave denosumab to patients with giant cell tumors, they actually saw generation of healthy bone out of this nastiness over here. So it works really well. Osteosarcoma is the most common primary bone tumor. It's an adolescent tumor for the most part, although we do see a second peak in elderly patients. Those are typically radiation-induced sarcomas in older people, occurring about 15 to 20 years after they received radiation for another type of cancer. Typically occurs in the metaphysis of the long bone, which is kind of at the end. Most common site of metastasis is the lung. They typically present with a painful, firm, warm mass that can cause pathologic fracture or limit range of motion of the shoulder, as in this picture. You can see it very well here on this MRI. We always get a CT scan of the chest. We also look at the bones, like in Ewing sarcoma, because you can have other bone metastases as well. These are aggressive tumors, and it's basically assumed that everybody with us, even if you don't see metastatic disease, they have metastatic disease. And when these are treated with surgery alone, even when you see no other evidence of metastatic disease, 5-year survival is only 10 to 20%. However, with adjuvant chemotherapy, it goes up to 55 to 80%. What we typically do with these patients is we treat them with chemotherapy, then we send them to surgery, and then they finish their chemotherapy afterwards. And the reason we do surgery in the middle is that it's been shown that the histologic response at surgery is prognostic, meaning that we don't often see tumor shrinkage with these. You give chemo, you don't see it get smaller, but their pain may get better, and then when you take them to surgery, you may see that even though the tumor is the same size, a large amount of it is dead. So our magic number, our goal with these is you want to get 90% necrosis at the time of surgery. It's been shown that if you can achieve 90% necrosis at the time of surgery, your long-term survival is 80% or better. If you do not see 90% necrosis, the overall survival is still not bad if it's resectable. It's still about 55% or maybe a little higher than that now, but it's unfortunately not as good when you get the high necrotic rate. Unfortunately, there have been a bunch of efforts to try to tailor the chemotherapy to the response seen at surgery, and they've all been negative. So a lot of places still believe that if you see a bad histologic response at surgery, you should change your chemotherapy up. Unfortunately, that has not ever been shown to be helpful, so we typically don't do that. In terms of chemotherapy, the standard chemotherapy is methotrexate, doxorubicin, and cisplatin. On several studies, unfortunately, that's a very toxic regimen, and it's not really tolerable for people over 40 years old. It's also not clear that methotrexate as much in people over 40. So in most of our adult patients, we use cisplatin and doxorubicin. Second line, there are a lot of options. Unfortunately, prognosis is pretty poor. So when these come back, long-term survival, very similar to Ewing's, is really limited. So we try to treat these. We try to get them treated and cured the first shot. Once it comes back, we have some options, but no great options. And if you look at this list, you see most of it's kind of old-style chemotherapy, and unfortunately, there haven't been really big breakthroughs in osteosarcoma in about 30 years. I think the last big breakthrough was in about 1986. So unfortunately, this is a disease where progress has really stalled in recent years. So that is the end of my talk. I hope you found it interesting, and thanks for listening.